871 in Medic 6, you're seeing a 74-year-old male, shortness of breath.
When responding to an MVA, you are sometimes the first to arrive on scene. So, what is your first priority? Safety. When faced with a complicated extrication, there are steps you should take to ensure your safety, your crew, and your patient. Prolonged extrications with entrapped patients present many challenges. Activities on scene can be chaotic and very distracting. Keep your focus and your primary goal in mind: patient care. Conduct a scene survey, including the number of vehicles involved and where the entrapped patients are located. Assess for hazards on the periphery of the scene that could interfere with rescue efforts or responder safety. Look for electrical hazards, glass and metal debris, spilled fuel, engine oil, antifreeze, or fire. Neutralize as many hazards as possible, or bring them to the attention of crews that can handle them. Look for occupants that may have been ejected or are hidden in debris. If the patient needs supportive care during the extrication, determine whether an inside position is needed. There are two basic ways you can gain access to your patient: simple access or complex access. You'll find that most incidents are simple access scenes. Simple access does not require the use of any tools or specialized training, but complex access will require specialized personnel, tools, and equipment.
Mark, is there anywhere we can jam a short ram in there and push from the bottom too?
Unless you are properly trained and have the resources available, do not attempt to extricate the patient in a complex scene. Call for resources and do it immediately. Also, advise them of any specific equipment needs or scene challenges. While you're waiting, provide reassurance and support to your patient. If heavy extrication is required and you do have adequate training, equipment, and manpower available, be sure you can extricate the patient safely without any additional resources. Remember, call early if you need more help. Vehicle stabilization makes the scene safer for everyone involved and can be completed in just a few minutes. A stable vehicle will protect your patient from further harm or additional movement. Stabilization ensures that rescuers working around the hot zone are protected from dangerous rolls or unexpected shifts, and it protects the responder inside the vehicle from additional hazards. Every response vehicle should have a basic stabilization kit. A variety of systems are available. The use will depend on the specific situation and scene hazards. These tools include wood cribbing, step chocks, airbags, hydraulic rams, come-alongs, jacks, chains, winches, and wedges. It's critical to monitor cribbing throughout the call. When different parts of the vehicle are removed during extraction or rescuers move in and out of the wreckage, cribbing systems may be compromised. Assess the vehicle. Consider the make and model. The number, placement, and deployment of airbags will direct your extrication efforts. The compressed gas cylinders in airbags can explode when cut, sending shrapnel-like fragments throughout the vehicle. Look for SRS warning labels on doorposts. If you'll be working inside the vehicle, providing patient care, do a quick survey of the interior before entering. Sight, sound, and smells can give you quick insights to potential hazards. Look for the deployment of airbags and enter from the deployed side. When inside, stay in the middle of the back seat if possible. This keeps you out of the strike zone of any undeployed airbag. Pull back roof liners to expose any SRS hazards and notify rescue crews of any hazards. Remember, when responding to a large or complicated extrication scene, it is important to implement the incident command system and have an incident commander as well as a safety officer overseeing the operation.
Seth, can you move it all? Just try to get yourself out.
Until the vehicle is stabilized, visually assess your patient from outside. When you can safely gain access, then you can perform a rapid hands-on assessment. If conscious, remind your patient not to move. Suggest they focus on something in front of them to reduce neck movement. When you're able to assess your patient, perform manual cervical spine immobilization. If you discover any compromise in the patient's airway, breathing, or circulation, you may need to consider rapid extrication. Communication between EMS and the rescue crew is critical. If you're inside providing care, your responsibilities include getting as much information as possible about the patient's condition and any potential hazards or entrapment challenges you observe. Assess the mechanism of injury. Clues from the interior damage can give you information about the severity of your patient's injuries and their level of entrapment. Assume that any part of the patient that you can't see is entrapped. Rescue crews outside should give you information about their progress, and you should keep them informed about your patient's condition. If the patient's condition is deteriorating, extrication plans may need to be revised. Rapid extrication is appropriate for patients who are unstable or when the scene is unsafe. For example, the vehicle is on railroad tracks, there is danger of fire, explosions, or chemical hazards, or if you are in a violent situation. There are several ways to perform rapid extrications. A team of 3 rescuers can move a seated patient to lying supine on a backboard in about 2 minutes. Manual support and immobilization is difficult with these maneuvers, risking possible spine movement. Do not use rapid extrication techniques if there is no urgency. Participating in hands-on practice and drills will give you the experience to quickly and safely maneuver your patients in these situations. You will need to administer oxygen and monitor the airway during a prolonged extrication. If airway management becomes a concern, ALS may need to place an advanced airway. Airway placement can be challenging in these environments. Following insertion, the placement must be continually monitored using an end-tidal carbon dioxide detector and a pulse oximeter. Fluid or circulatory support may also be necessary at prolonged extrication scenes. Intravenous fluid can help maintain a patient's perfusion, but there is some controversy regarding their use. IV fluids do not have clotting properties, they don't transport oxygen, and they can make bleeding more profuse. Consult your local protocols regarding the use of fluid therapy with trauma patients. Proper patient packaging helps protect your patient from further harm during extrication. Packaging means you have immobilized the patient as much as possible to prevent further injury, and that you have splinted fractures and controlled any bleeding. Even moderate bleeding during prolonged extrication can result in life-threatening blood loss. Crush injuries and the compression of an extremity can have a dramatic effect on your patient's condition as well. The buildup of lactic acid and the release of potassium and myoglobin into the bloodstream can lead to circulatory collapse and renal failure. This is known as crush syndrome. It's important to monitor vital signs frequently. Continuously reassess your patient's ABCs and provide critical interventions. Remember, psychological support is important as well. The scene can be chaotic and noisy. Provide reassurance and empathy. This can reduce the patient's anxiety, which lowers heart rate and can slow blood loss.
You know what? I'm going to be honest with you. It's going to take us 20 minutes of cutting on this car.
If resources allow, you can assign one person to the patient who can provide them with information regarding the rescue progress on a continual basis. Don't forget to protect your patient from other scene hazards during their extrication. The use of tarps or blankets can protect them from metal and glass hazards, as well as guard against hypothermia. Placing hearing, eye protection, or helmets on them can further reduce the risk of additional injury. Continuous C-spine immobilization should be maintained throughout the call. Watch closely and direct rescue efforts as the dashboard is pushed or other parts of the vehicle are manipulated that can harm your patient. Watch closely for impalements or other injury concerns. In some areas, EMS personnel are trained in extrication and have all the PPE necessary to work in a hot zone. In other areas, rescue efforts will need to be halted as EMS attends to the patient. Depending on your jurisdiction, it is a good idea to train with rescuers and develop response plans in prolonged extrication scenes. When extricating a patient, the primary goal is to remove the vehicle from around the patient. This will ensure that the patient's injuries are not further aggravated. Most often, power hydraulic tools are used. These tools can be used to spread, cut, pull, and push. They create tremendous forces. Any rescuer using this equipment should be well trained. Responders working in and around the hot zone should be aware of the hazards associated with its use. Other tools used to gain access include cables, winches, wedges, airbags, and jacks. Reaching your patient can be challenging depending on the position of the car, the environment, or the situation. Sometimes it is necessary to remove doors, windows, dashboards, windshields, and roofs. Participating in drills and practicing with different kinds of equipment, as well as working with a variety of vehicles in various positions, provides important training opportunities and can better prepare you at the scene of a real incident. No two extrication situations will be alike, but there will be similarities as well as predictable hazards. Some situations will require improvisation, creativity, and adapted techniques. Hands-on training, along with an understanding of how vehicles are assembled, how seats are adjusted or removed, and where airbags are installed, is invaluable. Scene evidence can give you clues to the potential for spinal injuries. C-spine immobilization is one of the main concerns when removing a patient. It is important to be able to assess and recognize injuries to the spinal column or cord. The handling of these patients is critical. Any improper movement can cause permanent disability or death. Follow your agency's SOPs regarding spinal immobilization procedures or selective immobilization protocols. Basic tools to help you immobilize the patient correctly include cervical spinal immobilization collars or C-collars, long backboards, and rigid or vest-type short backboards. Your goal is to keep the head, neck, and trunk in alignment. Long backboards are generally used for the patient who is found in a lying or standing position. Ambulatory patients found on scene often require immobilization after assessment or determination of the MOI. With these patients, the standing takedown technique is strongly recommended.
Can you feel this right here?
Mm-hmm. Kind
That
of
hurt?
hurts.
Okay.
Yeah.
For this maneuver, first establish manual inline stabilization and apply a rigid cervical collar.
We're going to put a board up against your back.
Position the board upright, directly behind the patient.
We're going to take you down on 3.
Okay.
1, 2, 3.
And with the help of 2 other rescuers, carefully lower the patient down to the ground. Then secure properly.
This is just going to
If your patient is seated, the vest type or rigid shortboard can be used. Short rigid boards help minimize movement and provide enough stability to the head, shoulders, and pelvis until the patient can be transferred to a long board.
My back's sore.
How's that feel?
Insert the device between the patient's upper back and the seat back and secure the upper torso straps.
Up. Got it.
Position and fasten both groin straps. Secure the head.
Got it.
Place the long backboard next to the patient's buttocks. Then, turn the patient parallel to the long board, slowly lowering them onto it. Lift the patient and the short board as a unit, slipping the backboard under them.
Ready, 1, 2, 3. Undo the ball.
After transferring, secure the patient to the board, immobilizing the torso first, then the legs, and finally the head, using straps and head blocks to prevent movement. Then secure the patient and board to the gurney. While moving the patient, try to maintain manual spinal immobilization as much as possible. There are many ways to remove a patient from a vehicle. With concerns of spinal injury, most often it is best to remove the roof of the car. In this situation, a long backboard can be used. After proper immobilization, slide the board between the patient and seat. Recline the seat and carefully lift the patient up the board.
Ready? 3, 1, 2, 3.
Secure and lift them up and out over the trunk. A Kendrick extrication device, or KED, is a vest-style immobilization device that can be used in these situations in addition to the long backboard. This device offers extra spinal support and has handles to assist rescuers in pulling the patient safely onto the backboard. After the patient is clear from the wreckage, they are secured to a long backboard and then transferred to a gurney. Once you've successfully removed your patient and have transferred care to the hospital or the transporting agency, take a few minutes to evaluate the scene. Discuss the methods used to assess the patient. What worked? What didn't? What were the main challenges? What could be done differently? A careful examination of the response and actions on scene can give you some valuable information regarding your crew, their weaknesses, or areas that would benefit from additional training exercises. During extrications, it is important to maintain your focus. Rescue and treatment can be complicated. Remember, your safety and patient care are the primary concerns, and the goal is a safe and quick removal. Your ability to adapt and improvise on scene is an essential part of the patient care. Coordination and communication with everyone involved is critical.
Action.
All right, sir, I'm gonna grab a hold of your head, keep looking forward. Sir, I'm late and I'm an ENT. What seems to be the problem today?
Lost my roof.
Lost your roof, okay. You have any neck pain?
Yeah, big time. Think my car made it. Anybody need any help? Anybody? I'm available. Oh, jeez. Swear to God, if I have 4 eyebrows by the time we're done with this, there's gonna be some heads rolling. I hope you're filming this.
You get your fingers out of that? No. Let's go, guys.
Let's not go do that again.